Good morning, everybody. I'm here from not so sunny today, Houston, Texas, Clear Lake area, coming at you for this special event, Trauma-Informed Evaluation Practices and Special Education. Before we start, I just want to thank you guys for being flexible with me. I have a 1-year-old and a just turned 4-year-old who have been going in and out of daycare, and because of the unreliability of their daycare, I have to pre-record some of these sessions to make sure they don't run in screaming, in just their underwear or anything like that and disrupt us. And it's just easier for me to do a couple little live 20-minute chunks for Q&A between each half of this presentation than it is for me to be online for 5 hours or 6 hours and expect them not to interrupt. So thank you so much in advance for being compassionate and understanding during this time. I know that everyone is having a really difficult time these days, especially if you're at home trying to manage multiple responsibilities. All right, so who am I and what do I have to say about trauma? So I'm a licensed psychologist. I am also an LSSP in the state of Texas. So I was trained as an LSSP originally in South Carolina and went on to get my PhD in school psychology. Right now I practice as a private practice psychologist. That's relatively new. But my training was not geared toward that. My training was actually in the schools. I was an English teacher before I came to this profession. And what really fascinated me as an English teacher in a high school in Sugar Land, actually, here in Texas, was just the differences in how kids learned, how they respond to different things. Some of my kids who had disabilities really intrigued me in terms of how can I help them? And my bosses kept saying, well, you have, 156 kids, you can't sit down with every one of them all day and figure out their problems. And I kept thinking but what if there was a way I could? So I went on that path to become a psychologist. When I was done with my internship, which I did in a rural part of Arkansas called Crowley's Ridge in Jonesboro, about an hour away from Memphis, or West Memphis, if you've seen some of the documentaries about that city. Very, very rural, very, very flat, and very poor area. And I went around doing testing pretty much all day. They called me the tester, and that was my job. And I really enjoyed it. The following year, I went to the University of Tennessee, so the other UT, and did a postdoctoral fellowship in child welfare and trauma-informed care. And that, I like to tell people that because of what I'm talking about today. A lot of my knowledge and experience comes from my time there in postdoc. I stayed on as a staff psychologist there and also did a lot of supervising and training in our clinics. We did assessments mostly, and then we also kind of on the side did supervise and train people in trauma-focused therapies. So TFCBT and parent-child interaction therapy, which we may get to later as recommendations. When I moved here back to Texas and dragged my husband with me, who is still at the University of Houston, Clear Lake, he's a professor as well in school psychology also, and also an LP and LSSP. We both were at the University of Houston, Clear Lake for the past 4 years. We both were in the school psychology department and also in the new PsyD program, which is health services psychology. So like I said, I quit in around January to become a private practice psychologist because I wanted to work more directly with teens and young adults. And while I was at UHCL, though, I did a lot of training of LSSPs. Probably any LSSP that came out of there in the past 4 years came through my clinical practicum and my internship. So I take a lot of pride in that. Had a lot of hands-on experience with those women and men. Recently, a couple years ago, I got certified at the national level in trauma-focused CBT, which is pretty much the kind of recognized gold standard in trauma treatment for kids and teens, and is now being, I think, extended a little bit upward from that. And I am a nationally certified therapist, so I do have some skills in that area. And again, a lot of what I know about trauma and my TFCBT background comes from my time at UT Center of Excellence. Most recently, the past few years, I've been working also on a lot of research related to trauma. So I try to hit it from all angles, the teaching, the research, the service, and the practice, obviously. But I co-edited with some colleagues of mine, Kirby Wyckoff and Aaron Gooby. We met each other about 4 years ago in the NASP, National Association of School Psychologists, Child Maltreatment interest group. And the interest group became a research group, and we did a national survey of LSSPs. Well, they don't all call them LSSPs, but equivalent. And we decided that we wanted to run some data just on like what people knew about trauma, what they wanted to know. And it kept coming up that basically the gap was huge. Like, I want to know a lot about it, but I don't know enough. And I don't feel supported in doing these trauma-informed practices. So you can read about that in that journal. We also cite in the special issue there, which is online, I believe, for free. If you just search TASP, Research and Practice in the Schools, it is a collection of different researchers talking about kind of the state of the science in trauma in schools. Really cool. And, and it references a survey we did a few years back about the same topic. The one I was talking about with the percentages of different people who said, it was like the majority said that they would love to do this kind of work, trauma-informed care, whether that was just, doing assessments that had a trauma element to them or making sure they were sensitive to it and knew about it, but they didn't feel like they had the knowledge or training. And so that started a bunch of these trainings that I have been doing for the past few years around this area. So that's me. I am so missing getting to be there live with you guys and meet you, but I'm hoping during the live sessions later today we can talk about who you are a little bit and I can get a better feel for what you want to know. So let's get started. Today we're going to answer 4 major questions. 1, what counts as trauma? Okay, there's a lot of stressful things. They're not all trauma. We know that, right? But how do you decide what's a trauma and what's not? We got to know that. What are its effects on students, people in general? Like, what do we know about the physiology, the brain, the body? What do we know about how it affects IQ? What do we know about how it affects behavior? We do know a lot about that. A lot of the research comes from child abuse research, which I'll talk a little bit more about later, but we do know quite a bit. That's the morning, and then there hopefully will be like a live Q&A in the morning. Before lunch, where I will pop on for about 20 minutes and answer some of your questions so far. So if you have a question before then, just, I guess, throw it in the chat box, write it down, and we will try to answer those before you go to lunch. When you come back for lunch, we'll do the next 2 parts. Part 3 is this kid in front of me that I'm evaluating or that is suspected of having a disability or has been referred. Has this kid been affected by trauma? And how? If he has, does he have symptoms? Is there any tangible effect that I can write down in the report, and if yes, then that's step 4 right here. How does that fit into my FIE? What do I do with that information? How do I interpret it? What does it look like? Does that count as trauma? Does it count for special education? Are they eligible? Are they not? If so, how do I write that? If not, how do I write that? And then we'll end with a little Q&A at the very end of the session. So welcome. All right, just to try to hook you guys in, I know from what I understand, I believe many of you are LSSPs, but probably even more of you are educational diagnosticians, which is something I was not familiar with, by the way, until I came back to Texas and learned those initials, but have been training some of you guys in different districts for the past few years. So I think I sort of know a little bit more about it, and so valued. All of you are so valued in our schools right now. This session today, yes, it's going to be relevant for those of you who are going to have to make some really hard decisions soon about things like emotional disturbance, ADHD, right? Are these kids being referred? Do they actually meet criteria for these disability conditions? Or is it like COVID? Or is it something else, right? So that is definitely going to be relevant. But I also want to speak to those of you who are like, oh my God, like I want to know about trauma. It's kind of interesting. I don't think I'll actually use it, in my work, but I just kind of know about it. So I actually do think it's going to be relevant because I'm going to show you in part 2, trauma is known to have some really salient effects on the brain, on physiology, on behavior. And besides behavior, that's what we usually think of first, but really widely replicated effects on specific parts of IQ and even on school achievement. There's some meta-analyses I will show you that I hope will kind of sell you on how important this is for all areas, not just the behavioral, the social, emotional, but also cognitive and academic functioning. So welcome. All right, part 1. What counts as trauma? That's our first question. We're going to go over a couple definitions and concepts, okay? So before we start, oops, I showed that already. Before we start, I want you to think of in your head, what counts as trauma to me? How am I going to define that, right? So I'm going to show you some pictures or images to help you think of some different examples of things that people might say are traumatizing. And I want you to think like, is that trauma? How do I know? So for example, a couple years ago here, we had the Santa Fe school shooting. We were very impacted by that here in Clear Lake. And I'm sure some of you were as well. But, the nationwide school shootings, like, are those trauma? Is it traumatic? Are those children traumatized? So think about that. And as you answer to yourself in your mind, and I wish we could do it in person, but as you answer to yourself in your mind, try to think about, like, if you say yes or no, why? And you're probably going to say it depends, which we are going to definitely talk about. What about Hurricane Harvey? For some kids, was this traumatic? For other kids, maybe it wasn't. How do we draw that line? So take a minute to think about that. Maybe stories you've thought of, kids you've known, maybe your own experiences. What makes something traumatic versus not? What about child abuse and neglect? So this is from our special issue. You'll see here on the left, there's a map here of the number of CPS allegations per 100 children in each county. And it's pretty high in Texas. We also know that underreporting is a problem, right? And we also know that in Texas, corporal punishment is legal. So where does it cross the line? When does it become abuse? When does it become traumatic, right? Because even like neglect, for example, that's the most common form of child maltreatment. It's very common, particularly in rural areas. When does that count as trauma? When is that traumatic? And last but not least, what about COVID? Is that traumatic? I've been seeing, I hear a lot of my colleagues in private practice especially talking about how this is kind of this mass trauma. And I just wonder what you guys think about that, and, giving you a minute to think about, is it automatically traumatic for everyone? Are there certain people for whom it's traumatic? Is it offensive to hear people say it's traumatic? Is it offensive to hear people say it's not traumatic, right? So there's a lot of questions here. We've been hit particularly hard. I'm speaking to you today at the very end of July, and these are the numbers as of today. Pretty stunning, right? So is it traumatic? What do we mean then when someone is experiencing an event like this, and then we say that they're quote unquote traumatized? Like, what does that mean? That's not a very specific word. So let's just get an idea here for base rates. A base rate is something you compare your kid to. Like if you're evaluating a kid, you're like, okay, well, how common is this in the population? And one thing we always learned is like, if you hear hooves, think horses, not zebras. Meaning like, it's more likely that it's ADHD than some rare genetic disorder that has behavioral consequences, right? So same thing, like let's think about how often does it actually happen and how often does that actually become trauma or traumatization? Which for the next couple slides, by the way, I'm going to define by research on PTSD type symptoms because that's how they define it in research, not how we're defining it. I know, we're not diagnosing PTSD. So there's 56.6 million students in U.S. schools overall, right? 0.4% of them have experienced some kind of gun violence, school shooting at their school. And if you go to the Washington Post, I think it is, Washington Post, they have this interactive graph where you can see which school shootings had how many victims and all that stuff. So of all of those people, 3 to 4 months later after the event, we only have research, by the way, on some really random places, because if you think about it, you have a school shooting, like you don't want to just jump in there and go do research. There's a lot of sensitivities you have to consider. So there's not a ton of research on this. But 3 to 4 months later, there was one high school, Jokela High School, I don't know how to say it, where 43% of the survivors of a school shooting showed post-traumatic stress-related distress. 19% had possible diagnosable PTSD symptoms. That doesn't mean, they weren't necessarily diagnosed, but these are like researchers going in and checking them all the time. 19%. That's not all of them. You would think, I don't know, I would just think like watching a show about a school shooting that everyone there would have been quote unquote traumatized, right? But actually only a proportion. At Virginia Tech, we see a similar breakdown. So Virginia Tech was quite a while back, but that was one of the first widely publicized school shootings. And we saw high levels of PTS. Remember, it's not the disorder, it's not the diagnosis, it's just symptoms related to post-traumatic stress, like avoidance, hyperarousal, negative alterations in cognition and mood, all that stuff, in about 15.4% of the kids who were there. So not all. Similarly, we will get way more into ACEs later. It stands for adverse childhood experiences, but just look at these, right? So physical, emotional, or sexual abuse, physical, emotional neglect, and then household dysfunction. So mental illness in the family, a relative in jail, watch their mother treated violently, substance abuse in the house, or divorce. So just think for a second. I know most of us at least have one of these, right? 77.4% of US kids have at least one, probably more, right? But only about 1 to 6% of US children are maltreated, meaning abused or neglected. So probably most of those kids are on the household dysfunction side, and there's kind of some problems with that in research in terms of saying that that's trauma. We'll get to that. But if that is trauma, like, it's so common, does that really count as trauma? And is commonality or rarity a criteria for trauma? It's not, but we often think of it that way. Like, well, that's really common. Is it pathological? So less than 1 to 6% of U.S. children are maltreated. Maltreatment covers abuse, neglect of all kinds. And if you look there at that graph, it's mostly 0 to 3-year-olds who get reported. And as they get older, either no one's reporting it or it's not happening as much. And this includes things like shaken baby syndrome, things like that. But even of those kids who have the worst adverse child experiences, i.e. maltreatment, only some of them actually develop traumatization symptoms, so PTS type symptoms. Depending on the study you look at and what kind of trauma and how often, all that, it's a pretty big range. 20 to 63% of survivors of this type of maltreatment develop full-blown PTSD. And of course, there's lots of factors that determine like whether it's 20% or 63%. Is it sexual abuse? We just talking, not just, but is it more neglect? Is it the type of abuse? Is it the risk factors we're going to talk about later? But my point here is that it's not all. It's only some. So we always think of like child abuse, like, oh, you must be traumatized. When I worked at the Center of Excellence for Children in State Custody with foster kids, we were always so surprised because they would be so much more resilient in person. Like, we'd get records faxed to us, or we one time got records in a box from FedEx, boxes of records, because this one kid had been maltreated for so long and had so many cases against his parents and all stuff. And when you read through this record, it was just freaking heartbreaking. And you expect that this kid's just going to walk in like a ball of sadness, right? But he actually was very high functioning. And that doesn't mean that we just ignored him and told him to go home, right? So there's other things you can do. But that is all to say there is such thing as resilience. There is such thing as post-traumatic growth. And so not all trauma comes from abuse, and not all abuse is trauma. So that's a kind of a weird... I know when I first started learning about this, it surprised me. Not all stress is trauma. So what I just said, right? I know for those victims of trauma who have experienced severe and repeated abuse, it is often disturbing to them to hear things called trauma that seem not, you can't compare pain, right? Everybody has pain. You can't compare one person's pain to another, but it is frustrating since we have limited resources, particularly in the schools. If we call everybody traumatized because, for example, they've been stressed, then what does that do to the people who really, really need those resources, like that top 1 to 3% of kids who are at the top of our triangle, right, who really need the resources? On the other hand, and also we don't want to pathologize something that's quote-unquote normal. So there's this idea in developmental psychology of anti-fragile, right? We're not like eggs where if you drop us, we'll break. We actually need a little bit of pressure, a little bit of gravity, a little bit of weightlifting to improve our stress response. So we need some of that stress. We need some kind of challenge. Now, when the challenge gets too much, that's usually what we call trauma. But there's been this idea of concept creep, which means like you have this concept and all of a sudden everything's being called that, right? Like, this is really common in education a few years, social emotional learning or grit or whatever buzzword of the day. Concept creep, right? All of a sudden everything is grit. All of a sudden everything is SEL. Like everything is not trauma, right? So same problem here. You also get a concept creep where it's a little blurry when people say like, oh, well, crisis is the same as trauma. Not always, right? You can have a crisis that doesn't develop into a traumatic situation, which we'll get to the definition in a minute, I promise. What about, toxic stress? You hear that a lot. Or daily hassle stress. There's this whole thing now that like being stressed can be equivalent to smoking 10 cigarettes a day. You've probably heard some statistic that way. That may be true, and we'll talk about the studies that started that rumor in a little bit. But, is toxic stress or daily stress, daily things you have to deal with, is that really trauma? It depends, right? And then there's this argument as well over, I'm sure you've thought in your head, like, is this an argument of degree or kind? So is it that it becomes trauma when it's a certain amount? Or is it like category, like this is trauma, black and white, this is not? I would argue that it's a degree problem, not kind. So same thing with like intellectual disability, right? Same thing. It's actually not that some kids have it and some kids don't. There's a distribution there of IQ, and we just arbitrarily put the cutoff somewhere and said this is considered disordered. So you'll see in a minute that with trauma, that's similar. We put the cutoff somewhere and we say beyond this, it's going to be considered trauma. Although it's not as reliant on numbers as a lot of things in IQ are. And some people call it like little t trauma, big T trauma. Big T trauma is like the kind of pictures I just showed you, right? Maybe like school shootings. And little t trauma more like, everyday types of things. Like getting into a fight with your mom or something, right? And that's not a technical term, but it's just something that you'll see referred to like in blogs. The other conceptual issue with trauma is the idea of single incident or event trauma versus complex or developmental trauma. Event or single incident trauma is mostly what people think of when they think of trauma. That single incident, because PTSD, by the way, all this stuff about trauma was developed in response to war veterans coming back from Vietnam. And although they didn't necessarily experience just one single incident, it was like a very isolated thing in their life. Like I had this normal life, I went to Vietnam, I experienced this traumatic situation that was very removed from my life, and then I came back and I had problems, right? So that's what all of our criteria, our interventions, everything is based on. Single incident or event trauma is that kind of thing. Or, like Hurricane Harvey, school shootings, things where there's like a definite, this happened and there was a before and there was an after. Versus what we know to be sometimes even more difficult to deal with, to tease out the effects, to look at whether it's, differential diagnosis type thing, is what's called complex trauma. A few years ago in DSM-5, they were trying to get this thing called developmental trauma disorder to be separate from PTSD because it was so different. It looked so different in kids. This is the kids who have early, ongoing trauma, abuse and maltreatment, neglect, domestic violence, etc. Like those kind of hard places, being from a hard place, right? And within the primary caregiving system, meaning usually like someone who's supposed to care for you, your mom or dad, or your uncle or your aunt, your sisters, your brothers, your grandparents, right? Early caregiving system happens early in your life and continues, and it's chronic. So that's complex trauma. It looks a little different from single incident trauma, and the treatments are a little different, right? So instead of trying to get over one thing, like, oh, this time you were in Vietnam, it's like your whole view of what life is and what morals are and what people are like is completely altered. Your internal working models are completely altered. And we'll get into this, but most of the research on the effect of trauma on the brain is based on complex trauma, which is this idea, right? So your brain is developing and you're having trauma all along the way, like you're being physically abused or sexually abused or neglected the entire time you're growing up and your brain is developing. Well, that's going to have a really big cascade of effects, one after the other after the other. So, a lot of conceptual issues with trauma here. But SAMHSA, which is the Substance Abuse and Mental Health Services Administration, government entity, says in order for something to count for trauma, you have to look at three elements, 3 E's. The event itself, how the person experienced that event, and what effects it had on the person. And this is similar. I don't want to give PTSD criteria because we're not assessing for PTSD. We don't diagnose in the schools. I like this framework better for right now because it's like we have to look at all these components. The event, what kind of event was it? Single incident, complex trauma? Was it, really, really, really scary? Was it just a little bit scary? I guess that's more experience. How the kid responded to it. So did they perceive it as threatening? When your kid falls and they look at you to see if they should cry or not, right? Kids do this. So something bad happens at school, they look to the adults to see what happened. What was their experience like? And then the effects. So those studies we just saw, 3 to 4 months later, what do these kids look like? Are they having behavioral problems? Are they having learning problems, attention problems, etc.? So in summary, individual trauma, according to SAMHSA, results from an event or a series of events or a set of circumstances, and I think that's a nod to complex trauma, experienced by the individual as physically or emotionally harmful or life-threatening with lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So a couple components here we just saw. Lasting adverse effects, that's the effect part. What's actually happening here? We will look at that this afternoon. Physically or emotionally harmful or life-threatening, that's what the event has to be. In the PTSD criteria, I think it sounds like actual or threatened death or harm, bodily harm. And you can, it doesn't have to be done to you. In PTSD criteria, you can learn about it, you can witness it. And for little kids, they can just hear about it happening to someone else. Experienced by an individual as, that's a really important part, because it's like I may experience that as traumatizing and you may not, depending on certain factors. What are those factors? Okay, so the event itself. These, by the way, are factors we know to be associated with worse outcomes in trauma. So more likely to develop PTSD is usually what this means. Again, it's just because PTSD is the way we research it. High degree of life threat. So like a really, fatal accident, a shooting, something really, really threatening to your life. And then people who experience interpersonal violence between two people. So there's this hypothesis that it's because it disrupts kind of your internal working models, your idea of how people are supposed to treat each other, what morals they follow, this idea of moral injury, like, oh, people are bad and I can't trust them and I can't believe that, that someone good or that a good God would do that, like those kinds of thoughts, right? So those kinds of thoughts are often brought up in interpersonal violence, I guess more so than something that's not necessarily caused by people. Okay. There's other things about the event you can get into with certain types of trauma. For example, like, degree of injury with physical abuse or with sexual abuse, if the person was related to them or there was penetration, how old they were. Those things all impact your risk for being traumatized after experiencing a potentially traumatic event. Factors within the child, so people who were exposed to traumatic events before, who already were traumatized in the past, and now they're more likely to feel traumatized by these events now. Girls are actually 2 to 3 times more likely than boys to develop PTSD after a traumatic event, and the mechanisms for that are still unknown, but there's a lot of ideas. Kids with existing anxiety or mood disorders or problems, more likely to develop that, and that may be partly because of the response section we'll get to in a minute. And then kids with disabilities, which I'm going to teaser alert here, and then in the next slide I'm going to talk more about that. But kids with disabilities are more likely to develop traumatic stress reactions than other kids. And that's all disabilities, like anxiety and mood disorders, sure, that falls under like ED, but also kids with intellectual disabilities, learning disabilities, ADHD, even speech and hearing. So the other factors that determine, who gets to that last rung on the ladder are family and school factors. Again, how does your parent respond? Do your parents have psychopathology like anxiety, mood disorders, PTSD themselves? Do you have poor family functioning to begin with? So like low levels of communication and support, and maybe some of those other ACEs, adverse childhood experiences that are in the home, like maybe a family member has substance abuse or is in jail, poverty, those kinds of things. I didn't even put that on here, but there are environmental factors as well, like poverty. Social support can be both a risk factor and, if you flip it around, a protective factor. So they've found in research that both parents and teachers are really important in terms of changing a child's risk or resilience under the face of trauma. And then response. How does the kid respond? This can be a big warning sign, so I want to put it in here for you guys. Kids who respond with high levels of anger to a traumatic event, and like anger and blame, rather than, we might expect more like sadness and grief, Kids who cognitively show that like depression pattern where they're ruminating on it all the time, thinking about it all the time, and kids with more, that's supposed to be a negative sign on the slide there, more negative appraisal of the event. Like, not those kids are saying like, I guess it happens, everything happens for, we have these kids that are sort of resilient in their thinking, but these kids that are the red flags are the ones that are thinking like, oh God, this is horrible, this is all bad, everything's always going to be bad, just kind of, I'm bad, everything's bad. Negative appraisal of events. And then kids who respond with avoidance coping, so trying to avoid reminders, avoid talking about it, high levels of avoidance. It's natural to avoid some of it, but purposely suppressing or denying it, or denying their feelings or their thoughts about the event, those kiddos are more likely to develop PTSD type symptoms. And then kids who dissociated at the moment of the trauma, which also reflects kind of an avoidant coping thing going on, dissociation. So movies always display this like it's some kind of automatic indicator that you're some kind of psychopath. But like dissociation is actually quite common. In a way, we dissociate every time we drive to work and go on autopilot. But kids who dissociate in the moment of the traumatic experience are more likely to develop PTSD later because they kind of haven't dealt with it actively. And then there was one more, talking about medical things since we have COVID that I didn't put on here, but kids who have like an emergency, like a medical emergency, or they were physically abused, when they arrive at the hospital, there's some evidence that the kids who have a higher heart rate when they arrive are more likely to develop PTSD symptoms. Probably due to the stress system response, right, which we'll talk about when we go to the body and brain section. So these things all make it more likely. I told you there was a teaser. This I think is really important for us. Children with disabilities are maltreated, so that's abuse and neglect, almost twice as much as other children. So why is that, right? Well, think about kids with ADHD and behavior problems first. Those kids are very difficult to manage sometimes. And sometimes parents don't have the resources to do it, so they are more likely to have things like physical abuse. And then think about kids with intellectual or hearing or speaking problems, kids who don't understand as well, learning problems. In Memphis, we used to see at the COE quite a lot of teenage girls who had things like Down syndrome or autism who were sexually abused at a very high rate. The idea being like, I guess the perpetrator would think, they won't tell anyone or no one will believe them, they won't understand. So kids with disabilities are more likely to be maltreated, which is, I guess to me, kind of the go-to form of trauma, the kind of trauma that seems to me most likely to result in traumatization. And by the way, during COVID, although child abuse reports are down, we think it's because none of the teachers and doctors are there to report it because kids aren't leaving their house. And so a lot of people are really afraid of that. I think even in the earliest months, March or April, it was down like 5%, which is a lot when you consider, I saw one stat that said like in Texas, or there was, almost 300 reports, and then like a couple weeks later, 200 reports a week, that's like 100 kids that, maybe didn't get reported. At the same time, the kids that do show up in the hospital for child abuse related injuries are having more severe injuries. So we think that probably the abuse isn't suddenly going down when people are stuck at home. It's probably going up. So although we will talk about, COVID itself and this kind of foggy sense of anxiety and that being traumatizing, to me, one big thing to be more worried about right now is these kids that are experiencing abuse and neglect, and even more so when they're at home during COVID-19. So let's go through a few scenarios to kind of show you that this can be different for different kids. Just because someone experiences a potentially traumatic event does not mean they're traumatized, right? They have to have these elements of the event, the experience, and the effects. So Santa Fe, for example, a school shooting. Let's say you have a child who was in the room at the time of the shooting, knew the perpetrator and or the victim. So that's parts of the event. Their experience was they did feel like they were going to die and they were extremely upset about it, right? So they felt threatened, they were threatened with actual death or bodily harm. And let's say like the within the child factors, right? Let's say they also had an anxiety disorder already that they were not being treated for, and they had high poverty levels at home and, some social support, but not great. They weren't doing great in school, for example. They had other risk factors. And then that kid, we would say, probably is much more likely to develop effects of the trauma and be considered, traumatized or having traumatic impact than a kid who, say, was in a different end of the building or maybe off campus that day, which, by the way, I'm not saying that kid isn't allowed to have trauma. They might be traumatized as well for other reasons, but that first kid is more likely to be traumatized depending on these factors, right? We would guess probabilistically. And maybe that second kid, came late to school that day and didn't actually, see anything happen. And he has really strong family support and a really good friend group, very connected at school. He didn't experience this actual threatened death because he wasn't there. Now, that kid could still develop PTSD symptoms. He did still experience something that was potentially traumatic at school, but without all the risk factors, that's why they're risk and not definite factors, it would be probably less likely. Think about Hurricane Harvey. So we had a kid in our clinic a couple years ago who came in and he was having anxiety, panic attacks basically because he had some certain risk factors. He had been traumatized already as a child. He had been in foster care and then adopted. So he had, unrelated trauma, but still trauma. His stress response system was already really sensitive. We'll talk about it. But every time it rained, he had flashbacks to his house flooding and to his parents being injured and just needed a different kind of treatment than maybe someone like, my children who were at home and too young to actually see what was going on. Although, side note, young kids probably pick up on more stress than we think they do. But, my kids at the time, our house wasn't damaged. It didn't flood. We don't have pre-existing trauma. They didn't have anything in their history that would have predisposed them. So they were probably okay. They probably experienced some amount of stress because of the stress in the household and in the community, but they recovered, right? So this child we had to work with in the clinic because he was having a lot of anxiety attacks about kind of flashbacks, PTSD-related symptoms because of the event, because of his reaction to it, because of his prior experiences, and because of some of the lack of support factors, and had a lot of risk factors as well. I believe he also had ADHD. What about child abuse and neglect? Like I said earlier, not all kids who are abused or neglected end up with trauma symptoms. In fact, many of the kids that came through my clinic that were in foster care and were there in Memphis because they had been abused or neglected, many of them did not meet PTSD criteria at all. So, you can imagine the different types of kids who would fit into either one of those categories. So, for example, we had one set of kids who had autism already, so there you go, disability. They were both nonverbal. Their mom had a drinking problem. She left them in the room while she was gone for multiple hours on multiple days. And of course, they developed things that looked more like PTSD versus, kids of the same age who just kind of grew up with a mom that may have also had a substance use problem, but they had a supportive stepdad that was there all the time. They didn't have any pre-existing vulnerabilities. Maybe this child was a boy instead of a girl, these kinds of factors. That child is less likely to develop trauma. And then last but not least, I've heard this talked about a lot. Again, this doesn't mean that they can't develop trauma, but my guess is that someone who had a very high stress level during COVID, maybe their parents experienced a ton of financial instability. They already had, stress in the home due to other reasons. Maybe this was a little girl who's 2 to 3 times more likely with a disability, maybe who also, actually had a death in the family. That child is going to be more quote unquote traumatized, of course. We would predict, not definitely, because it depends on all those factors, than someone who, again, like my children, we were very fortunate. We have all actually had COVID and it was very mild and no one died. And we have been, financially okay. We've had food and everything. There's been some stress, but it's been okay. They're probably less likely. So knowing all of this, let's wrap up part 1. We kind of know what trauma is now. We have to have the event itself has to be, actual or threatened death or physically or emotionally threatening. And we have to have the experience where we feel like we're either going to die or we're going to be hurt. It's very scary. People around us are not responding well. maybe we have some pre-existing risk factors like having a disability, being a girl, and prior trauma. And then we also have the effects. So what we're going to be looking for later today is those effects. Like, what are those symptoms? That avoidance, that hyperarousal, all of those types of things. And we know that we need those three things: the event, the experience, and the effects, to consider it trauma. All those things together are trauma, by the way. The event we call a potentially traumatic event, and then the experience is maybe you experienced it as traumatic, and then the effects is like effects of trauma. None of those are really trauma itself. So trauma, we consider that whole thing. So when I got asked to do this presentation, I was asked to talk about trauma-informed care. Now that's kind of a buzzword right now, kind of like SEL, right? But SAMHSA, same place that I got the definition of trauma from, they say that there's 4 R's of trauma-informed care. This has been adapted in many ways for schools, but this is kind of, let's go to the source. They say to be trauma-informed, and this is, by the way, a system. I don't think a person can really be trauma-informed. It's an entire system. So it's going to take your whole school, your whole district. It's a process, and it's the whole system. But we're working toward it, right? This is the first step. We got to realize the impact of trauma. That's what we're going to talk about today, especially in that next, we just talked a little bit about it, but we're talking about a lot in the next section as well. We're going to recognize the signs and symptoms. Again, we've started that a little bit. We're going to talk about it in just a minute this afternoon, when we talk about assessment. And then respond. How do we integrate that in the FIE? What do we recommend? Resist traumatization is re-traumatization is that last part. Again, that's a systems level commitment. So a lot of those things today I think will indirectly influence that. All right, so that's the first bit. What is trauma? It involves having an event, an experience, and an effect. It's not just one thing. Kids can experience it differently. That is what we consider trauma. So next up, after we come back, we're going to talk about what are its effects on students, and I'll see you in a minute.